Hi, everyone. Good afternoon. Thank you for joining us on today's webinar. I'm just going to give folks a couple more minutes to trickle into the event, and I'll probably get started around 12:02. Okay, so let's go ahead. So welcome everyone to Advancing Primary Care in New York, Insights and Opportunities for Investment. I'm Victoria Russo, Program Officer on the Primary Care team here at the New York Health Foundation. I want to thank you all for joining us for this timely conversation on the future of primary care and the opportunities emerging to strengthen investment across New York State. We're fortunate to have an excellent panel with us today, and I'm looking forward to a thoughtful discussion. And first, I'm going to start with a little bit of housekeeping. So as far as admin goes, closed captioning is available, and you can find that through the icon at the bottom of your screen, as well as the banner at the top. We will be recording today's session, and we'll be providing a recap after as well that will include the recording, as well as any materials that are shared in the chat for your convenience. I also wanted to note that we encourage participant engagement. So while your video and audio are disabled, we invite you to use the chat box throughout the event to share questions, and we'll be addressing those questions as best we can, whether that be throughout, responding in the chat, or waiting until the end when we'll have a brief Q&A session after the discussion wraps up. So just to set the stage a little bit, primary care is foundational to a strong health system. It's critical to improving health outcomes, advancing equity, and helping communities stay healthier overall. Yet primary care continues to face significant challenges, including workforce shortages, financial strain, and growing demand for services. Today, we'll be exploring new research, lessons from states already advancing primary care investment, as well as strategies to improve access, workforce sustainability, and care delivery across New York State. And finally, before we begin, I just wanted to note that as a private foundation, the New York Health Foundation does not participate in lobbying activities, and today's conversation is intended to be educational. So with that, I do want to briefly introduce our panelists. Today, we have joining us Kevin McAvey, who is the Managing Director at Manatt Health. We have Beth Bortz, the President and CEO of the Virginia Center for Health Innovation, and my colleague, Mary Ford, who is the Director of Policy and Research at the New York Health Foundation. And to start us off, I'm going to turn to Mary to give us a brief overview of the state of play in New York right now, as well as some critical data to get the conversation started.
Wonderful. Thank you, Victoria, and thank you everyone for joining this afternoon's discussion. I'm going to kick off the conversation by a little stage setting, giving an overview of some recent data and key considerations at the forefront of primary care conversations in New York. I will be sharing data and information from the co-published 2025 State of Primary Care in New York data brief. The New York Health Foundation published this in partnership with our partners and friends at the Primary Care Development Corporation, or PCDC. I think we will get a link to that dropped into the chat momentarily, but the information in this data brief provides kind of a useful framework and background for understanding both the urgency of the moment and some of the policy choices currently in front of us with this state. In this brief, we focused on three interconnected areas: primary care workforce capacity, rural access, and investment in primary care. Across all three of these areas, the data really point to increasing strain within the system coinciding with increased need. In New York, we spend about $300 billion a year on healthcare. This is one of the highest per person per capita amounts in the nation. But New Yorkers only have kind of average health outcomes. And in many areas, New Yorkers have very stark disparities by income, race, ethnicity, and geography. So more money is not getting us the outcomes that we're paying for. A few data points have really struck me when we were putting together this brief. Approximately 4.7 New Yorkers live in a federally designated primary care shortage area. That's about a quarter of the state's population. And at the same time, more than a third of New York's PCPs, physicians, are over the age of 60, raising some alarm bells about retirement-driven attrition over the next decade. It's estimated that the state would need at least 1,000 more additional primary care providers to meet current demand, and the kind of pockets in the state where that is not evenly distributed. Importantly, and this is something that I think overall has positive opportunities, is that the composition of the primary care workforce is really changing. Nurse practitioners and physician assistants now account for about 30% of New York's primary care workforce, which has increased significantly the last decade or two. So I think this evolution is significant because it's showing that a lot of the pressures that are affecting primary care today aren't just physician supply issues. The workforce conversation is increasingly not just about pipeline expansion, but also about scope of practice, reimbursement, alignment, retention, and how primary care teams are structured and how they are supported operationally. In this report, we also touch on a few regulatory barriers that continue to shape workforce and utilization in New York. One example is that New York still is the only state in the nation that does not allow trained medical assistants to administer vaccinations. And some of this has become kind of part of broader conversations about workforce flexibility and capacity. Not surprisingly, I think to anyone working in the primary care space anywhere across the country, but rural counties, rural regions continue to have substantially lower number of providers and provider densities. And they also have a much greater dependence on financially vulnerable provider infrastructure, which I think is an important point. And these access issues are occurring within a broader context of financial pressure across the delivery system, not just primary care, but certainly including primary care, particularly for independent practices and rural hospitals that are operating on really narrow margins and have very significant workforce recruitment challenges. So this all kind of brings us to the third issue we touch on in the brief around primary care investment. At the offset, I said that New York was spending more than $300 billion annually on healthcare, and only in about 3 to 5% of those dollars are being directed towards primary care. Again, that's 3 to 5% of total healthcare spending to primary care, all the while primary care visits about a third of visits. So a pretty clear disconnect between those two. A lot of the data we look at also helps make the case for how this imbalance has real downstream consequences, leads to things like higher avoidable ED visits, higher hospitalizations, poor chronic disease management, and ultimately higher long-term cost care. One of the more striking data points in the report is that roughly 7 in 10 hospital-based emergency department visits are considered non-emergent or potentially treatable in a primary care setting. So I think the current debate is not just about increasing support for primary care as a sector, but it's really about how the state defines value within the healthcare system overall. So should financing continue to disproportionately sort of reward acute and downstream utilization, or should the system rebalance investment towards prevention, continuity, longitudinal care management? And those questions have become really central in New York policy discussions over the past several legislative sessions, particularly as related to the Primary Care Investment Act. This legislation, which will drop the specific bill numbers also into the chat, this legislation would function to increase primary care spending through healthcare plans. It would essentially require health plans that are spending below 12.5% on primary care to gradually increase their investment by about 1% a year until that 12.5% target is met. Supporters of the primary care investment bill argue that New York has historically underinvested in primary care relative to total health spending, and that establishing measurable targets would help strengthen access, improve equity, and reduce avoidable downstream costs. As of this session, the bill has continued to advance in the legislature. It's currently on the Senate floor, and it is in the Assembly Ways and Means Committee, and remains part of an active discussion kind of more broadly about healthcare affordability and workforce policy conversations in Albany. So as we move into today's discussion, I think we're really thinking about what would it actually take operationally, financially, politically, to move primary care from being a really small percentage of healthcare spending to being treated as the foundational infrastructure for population health and system sustainability that it is. And so with that, I will turn it back over to Victoria to start some of the conversation.
Thank you so much, Mary. That was so appreciated and really grounding us in what's happening in New York right now as we now dive into the conversation with Kevin and Beth. So I wanted to start out by giving you both an opportunity to level set by asking what lens you are coming into this conversation with from the work that you've done in the primary care space. So Beth, I see you right below me, so I'll have you go first and then we'll jump to Kevin.
Sure, happy to. Hi, everyone. I'm Beth Bortz. I'm the president and CEO of the Virginia Center for Health Innovation. We are a nonprofit, public-private partnership, really with a role of serving kind of as the trusted convener in the Commonwealth of Virginia, with a focus and mission on accelerating value in healthcare. Most recently, kind of the reason I'm here, I think, is because since the pandemic, we have staffed for the Commonwealth the Virginia Task Force on Primary Care. We also have created a research consortium across the state to help connect our state research, health science researchers with state data to really improve our ability to analyze tough public policy problems. And so, today, I mean, I would just, let you all know that we've been at this since 2020. We kind of had a perfect storm of opportunity, I would say, in 2020, where we had almost every national primary care leader, pediatrics, family medicine, U.S. Preventative Services Task Force, were all Virginians. And we had a physician governor. And I thought, if not now, when? Like, this is the moment. We've got the right people at the table. We also had a pandemic that was threatening the very sustainability of independent primary care. And so that really is what motivated us to come together. And we've been hard at work at it ever since. I will tell you, 6 years in, which it's crazy for me to say that. I think in some ways we really underestimated the thorniness of the problem. And we've been doing a lot of work to try to address it. And I'm happy to talk more about that today, but I'll punt it over to Kevin to introduce himself, and then I'm happy to dive in and tell you about the different things we're working on.
Thank you so much, Beth. And VCHI is a tremendous organization, and thank you for all the work that you're doing down in Virginia and really helping us think about where we all move forward from here. Really nice to meet you, everyone. I see the participant list, and it's nice to see so many friends on the call. My name is Kevin McAvey, and I'm a managing director at Manatt Health, where I work with states across the country to help build capacity within our health care ecosystems to ensure that people who are making decisions about and within our system of care, from policymakers and regulators to clinicians and patients, have the data and information they need to make the best decisions they can make. Quite often, this is about shaping a healthcare system that works, care management programs that are effective. And so often that starts with making sure we have a strong and sustainable primary care system. And so my remarks today will probably have a heavy and biased emphasis towards the need of having better data and information. But I also wanted to emphasize, like, another part of who I am. I'm a born and raised New Yorker. I now live in northern Westchester, raising three kids of my own with my wife. And for those who have kids on the call, I think you could probably empathize with this. We have never interacted with the healthcare system more than we do now with our 6, 4, and 1 year old. There's rarely a week that goes by that the cold's not going through our house, a month that goes by that we don't have to go and visit a doctor. And I've never fully appreciated just how primary care physicians and clinicians are the bedrock of our healthcare system until you have a reason, personal or familial, to start to interact with that system. They are our first point of contact and are often our gateway to the care we need when we need it. But like so many across New York and across our country, my wife and I often find that these trusted partners of our can often be out of reach when we need it, when we need them, resulting in visits to urgent care or the emergency rooms for diagnosis or treatment that are more often than not more efficiently delivered in a doctor's office. And this circumstance has only grown more frequent since our primary care provider was acquired by a national entity. And so I come to today's discussion as someone who spends every day working with so many states across their country from the big picture, but who also feels our circumstance in New York very personally on a daily basis. And I'm really pleased to, Mary, thank you for having me, and Victoria and team, and Jane and Beth. So nice to be able to serve on this panel with you.
Excellent. Thank you both so much. And Kevin, that was a really great point that you made, in that when you as an individual or as a family start interacting more with the health system, you become so much more attuned to the challenges as you're facing them personally rather than dealing with them professionally. And it's something that here on the primary care team at the New York Health Foundation, we talk about a lot, in that we are individuals that are so well equipped from an educational standpoint, from a professional standpoint, to navigate those challenges. And yet we still face them on the day to day. We are still trying to figure out how to get into our doctor's office, how to avoid an unnecessary trip to the urgent care or the emergency department, et cetera. And that just further incenses us to do this work and to strive for this change for those who are not in the same position as we are educationally, financially, economically, professionally, and aren't able to navigate those challenges in the same way. So I'm really glad that you mentioned that, and that you pose that to sort of start the conversation as well. So diving right into sort of the meat of the conversation here, Manatt published a report that makes clear that primary care is foundational to better outcomes and lower costs, yet New York invests far less than its peer states, around 4% of total health spending. So Kevin, I wanted to ask you, in relation to the report, how should we understand the consequences of this underinvestment for New Yorkers today? And what's most at risk if that status quo continues?
You always have the easy questions. So, yeah. So, like when we think about underinvestment in primary care, it's important, again, like to your point, to really kind of think of it as not an abstract issue. It's an issue that affects New Yorkers every single day. It results in too many New Yorkers entering care late, episodically, in more expensive settings. And it's because the front door of our healthcare system is often too narrow to meet the need. And when the primary care system is too narrow to meet that need, the burdens, I also want to note, as you alluded to, don't fall evenly. They fall hardest too often on the populations that are most at risk or that are most disconnected from our healthcare system. And so when we think about underinvestment, I think it's worth briefly reminding everyone on the call about the impact primary care has on improving health and bending the cost curve from the research that's been done everywhere. And thank you for putting the brief in the chat. I hope folks can kind of skim that at an appropriate point. But in brief, like nationally, study after study show that having greater access to primary care is associated with better health outcomes. And it's not a mystery why. I mean, when you think about primary care, that having access to primary care promotes disease prevention, detects health issues early, supports chronic disease management, supports coordination and maintaining care connections once you are kind of connected to the healthcare system, and ultimately results in lower mortality rates, fewer ED visits and hospitalizations. It improves health. And primary care also serves as a critical entry point to the healthcare system for everyone. Expanding access to primary care has a particularly acute impact on historically marginalized populations. You mentioned earlier, and I'll come back to it, I think, a little bit later, some of the rural populations in our state where primary care access is so strained and people have to travel great distances even just to get access to primary care when it's available. I would also note some of our urban centers similarly have challenges in access for primary care. So it improves health. It helps to bend the cost curve, lower overall healthcare spending, and more efficient use of healthcare resources directly connected to having access to primary care. Primary care, again, like helps to identify and manage disease progression earlier and can generate long-term savings by decreasing utilization of costly acute and specialty care. I mentioned earlier having to go to the emergency room for something that just amounted to croup when we could have just gone to a primary care provider if they had appointments available locally. And again, those are kind of real lived experiences. If we have a strong bedrock of our healthcare system, it can help everything work in greater concert. And there are studies, again, time after time that show this. Something that came out from a PCDC brief recently, it had a statistic that the average emergency department visit in New York is at about $1,200 versus around $300 for a primary care visit. And we know from personal experience that many of those hospital-based ED visits are non-emergent or treatable in a proper primary care setting. So where are we, back to your question, Victoria, of like nationally and then in New York? In the US, we spend between 5 and 7% of our total healthcare spending goes to primary care investment, which I'll note is actually like less than half of many other developed nations. And that proportion may be declining over time. And in New York State, we're even below that at only around 4.1% based upon the latest data available, which I think is from 2022, and we'll get to that in a minute. But it's a proportion that's remained even or even declined over the past decade. And I think Beth will speak a little bit to this about when we talk about Virginia. And the result is that New York also lags on critical indicators of healthcare access and outcomes. Just to talk about access for a second, as Mary was alluding to, across both rural and urban areas in New York State, nearly 5 million New Yorkers live in an area without enough medical providers. New York ranks 40th among states in meeting primary care needs. Rural communities continue to face provider shortages. Around 15% of New Yorkers report not having a regular source of care. It's about like 1 in 8. So these results aren't an accident in my view, and they're a result of a market that isn't quite meeting the healthcare needs of folks who are living in our state. And it's a prime opportunity for a fix. Failing to rebalance our system to ensure primary care is adequately funded will continue to perpetuate a troubling cost structure in our state and in our country. More EDUs, that's avoidable, more preventable admissions, unmanaged chronic illness, more pressure on hospitals and specialists to absorb the needs that should have been addressed upstream. And again, I think all of this is very much connected, and underinvesting in primary care in New York winds up leading to some of these long-term issues.
Absolutely. Thanks so much, Kevin. That was incredibly insightful, as always. I wanted to sort of follow up in that and thinking about sort of why we're talking about this now and sort of the policy window that we find ourselves in that the report notes that nearly 20 states have already taken steps to measure or increase primary care investment. And I think balancing that 20 state number and thinking about those who have taken steps and how you just mentioned New York ranks 40th in thinking about primary care overall. What is driving that momentum across states right now? And why is this particularly important moment for New York to act? And I think you can lend yourself to the New York piece. And then Beth, it would be amazing if you then talked about sort of where that momentum came from and a little bit more about Virginia afterwards.
Sure, I'll kick us off, and I'm really looking forward to hearing Beth's perspective and all the work that she's doing in Virginia. So, why now? There are many reasons. There, like, because today is better than tomorrow, in my view. But I think a pervasive issue that we feel every day, and that all of us are talking about often, is affordability. Unsustainable healthcare spending growth is a primary imperative that we need to address, and there is no better time to address it than today. the cynical side of me and just kind of seeing how a lot of these policies are implemented across the country. I think that this is a advancing primary care measurement, advancing primary care investment can be seen as something that many stakeholders can get around. The trick is ultimately like how you do that without kind of perpetuating cost growth beyond that. Again, something I think Beth will be speaking to a little bit. And states have been playing a leading role in taking these steps. Like over time, cost growth has led states to leverage their roles as regulators and major purchasers in the market to push policies like such as primary care investment targets that aim to curb unnecessary and expensive specialty care to get care supported in the right settings, reduce avoidable ED and hospitalizations. New York, as you mentioned at the top, Mary, has some of the highest per capita healthcare spending in the country. So the imperative is high and pressing. And it's not just an easy fix. And I want to kind of make this clear. It's a complex problem that we need to solve within our healthcare system that requires long-term planning to really rebalance where our healthcare dollars are going. This may include, for example, not just targets to understand where we're starting and where we really collectively want to get to, but VBP policies that align across payers. Those require data and infrastructure to ensure that those who are responsible for implementing those VBP policies have the infrastructure they need, the information they need to do it well, and of course, contracting alignment. We need the workforce that's in place. Right now, the incentives in our workforce favor recruitment and retention for lucrative specialty care. How do we reverse that to make sure that primary care, which is currently seeing declining numbers in New York State, and Mary, you mentioned, has an aging population, gets new members into the workforce in New York, and we have public policies that recognize and respond to new market incentives and actors. Of course, I'm talking about corporate consolidation and the entree of private equity into our markets. How important is it, is a question I ask for myself, like to have independent physicians who can guide patients to high-value specialty providers and through the healthcare system? For me, I'd venture it's very important. But from the local to national level, I don't know if our policies have necessarily matched to our values and our aspirations at this point. The one other thing I'll mention before I shut up is for why now. There's a tremendous influx of money that many states are getting amid all of the bad news that we hear about every day with the Rural Health Transformation Program. And as we're talking about primary care deficiencies and shortages, those deficiencies are particularly acute in our rural areas. With New York in federal fiscal year 2026, I think receiving around $212 million in federal funding. How do we leverage this funding and this opportunity, like many states, to strengthen our rural primary care workforce and create a more sustainable healthcare system, particularly in more rural areas of the state, as well as in communities that are often detached from the healthcare system? So, Beth, I'd love your thoughts on this too. I know you're doing tremendous work down in Virginia.
I guess I'd start with the why now, which was the first question. And I would say, because this work is way harder than you think it's going to be, and it's going to take you way longer. And so you best get busy, would be my first statement. When we started down this pathway in 2020, it was really a concern, as I mentioned, about independent practice going out of business during the pandemic. I mean, they did not have the operational reserves to be closed for 6 months. We quickly found that they were not connected, right, to our health departments to do vaccination. They weren't connected to hospitals to get PPE. They were just kind of, struggling out on their own. So that was the first motivator. The second piece is, and maybe, you'll find that I'm a person who, like, I just tried to move us in Virginia very quickly past the why to the how, because primary care is a public good. It is the only public good in healthcare that is well documented. So we know that it is the foundational building block of value, absolutely essential. And any data that you look at suggests we are doing it poorly in the United States. I mean, you can pick a million different measures. And I would say, don't spend too much time picking those million different measures, because you're just going to come to the same conclusion. We've got to do a whole lot better So the challenge is how? How do we do better? How do we advance an agenda? Because pretty much everyone, so our task force on primary care, I tell people it's a third, a third, and a third. A third clinicians, a third state government, and then a third employers, health plan CEOs. No one disagreed that we needed to do more, to invest more in primary care. That's not the conversation. Everyone agreed that independent primary care was important to maintain. The challenge then becomes how? How do we do this? And how much appetite do we have for upsetting the rest of the apple cart in healthcare? Because, we started our work prior to HR1, when it wasn't quite as much a financial doom and gloom scenario. But even then, people were less than enthusiastic about expanding the pie. Now I can guarantee you people are less than enthusiastic about expanding the pie. And even rural health transformation, which, Kevin, I appreciate that you brought that up, but I have to tell you, it's a one-time 5-year driven at sustainability. It's only going to very marginally help primary care, because it's not going to change payment.
It's a silver lining on a dark cloud, Beth.
Right. It is what we've got, right? And we're all trying to figure out how to make it work, but I want to keep it in the perspective of what we're, the $1 trillion that's coming out of healthcare with the $50 billion that's coming in. So just, keeping that perspective. So, when we got down to the like, how are we going to do this? I'm just going to tee up a couple of the really tough things that we have had to wrestle with here in Virginia. Data is by far the biggest, being able to know how are we doing? We created a scorecard. We were the second state in the country after Massachusetts to create a scorecard. Starting to look at issues like access and workforce. And I'm going to tell you, Victoria, you raised a really good one that I made a note that I had to say something about. We cannot pipeline our way out of this problem. Virginia data suggests that those that are most interested in leaving, oh, look, now I'm giving myself a thumbs down. Those that are most interested in leaving primary care are newest to primary care. So you can't, as one of my task force members says, if the job sucks, the job sucks. And, you just can't keep putting more people in a sucky job and thinking that they're going to stay. So we have to figure out retention. And that means things, payment, administrative burden, all of those challenges. So we have worked hard on retention issues here in the state. The really alarming thing is we were the first, I think, to look at retention among APPs in primary care, because we were told advanced practice providers were going to be the solution for our declining physician workforce. They're burning out at faster rates than the primary care physicians. So, and only 1 in 3 is even going into primary care. So, you've really got to start to wrestle with your state's data and understand the nature of the problem. We have dug a lot into investment. You'll see we have an investment report. And we're just about to release the newest version of the investment report, which is our 2026 report, which uses 2024 data. And what you're going to see is that primary care investment in Virginia has increased. But as a percentage of total cost of care, it's decreased. So that's a challenge when you think about setting an investment target, right? Are you going to be holding the rest of the healthcare system? And I use system loosely because we don't really have a system, but are you going to hold the rest of healthcare, to a target limitation so that, primary care actually becomes a bigger piece? That's a question. How are you going to define primary care? I can't even tell you. When we started this work, 11 other states had already done some investment work. And every one of those 11 states define primary care differently. We right now define primary care differently than the national report does, that Milbank puts out, which is a great report. But to be honest, we look at it in Virginia and we're like, we don't like your findings because we actually have better data than Milbank has, because Milbank has to rely on the lowest common denominator data that works for all 50 states. Like, we have a really good all payer claims database here in the Commonwealth of Virginia. But even with that, we've been working now on requiring the our health plans to submit non-claims payment information. If you really want to talk about primary care spend, if you look at my report, it's all claims based because that's the data we have. But as we move to value-based payment in Virginia, significant portion of primary care payment could be in non-claims payment. We don't have access to that data. We have to get it. So I'm just trying to paint a picture for you that there's a lot of pieces to this that really have to work together in order to make a goal of increasing investment possible. And I am very, very grateful that in Virginia, our General Assembly has seen how important it is to have this convening of leadership across the sectors continuously meet. They fund that work for us. They have, want us to build a really strong data repository so that we can begin to answer these questions and set a target. So we're looking at a target, but we actually haven't locked into a commitment to setting a target.
Yeah, so Beth, I'm going to actually ask you a question if that's okay. And I'd encourage everyone else who's listening along. I see so many of you. Like, please put your questions in the chat, and I think we'll have a couple of minutes at the end for all of us to respond to them. But Beth, I love your concept of moving from the concept to the how. Like, how did you get there in Virginia? How did you get the legislature bought in? And then what does it take? And what were the challenges or surprises along the way, including the stakeholder surprises? Who was for this? Who was against it? How did you navigate getting from concept to the implementation?
Sure. I should say I'm fortunate that in my career, I have worked for the Virginia General Assembly. I've worked for the Medical Society of Virginia, and our offices were at the State Chamber of Commerce. And that's important because I really needed all perspectives. I needed to really think about how we could build a strong collaborative that was going to work on this. And one of the things that I found was that was a little bit of a pleasant surprise was that our health plans were very much committed to sustaining primary care. And the primary care clinician community really didn't understand that and really hadn't been utilizing that partnership very effectively. So that was kind of the first piece. The second piece I would say is that because I had worked for the General Assembly, I knew that legislators were not going to read lengthy reports that I was going to put together. So I literally gave them one bullet the first year, and that bullet was that using a narrow definition of primary care, Virginia Medicaid was spending 2.5 cents out of every dollar. Using a broad definition, that number went to 5 cents. And I asked anyone if they thought that was adequate. And the answer was no. That's all they needed to know. Then they were like, what do we have to do? But I mean, the buy-in isn't hard to get on this. In that first year, we gave them a really simple task: increase Medicaid payment by 10%. And they did it across the board for Medicaid primary care services. I would like to say that we've continued to get increases. We haven't. We've been working on trying to figure out how best to do that. But we did get, I'll give you one other example that everyone was very interested in. When we talked among providers, everyone saw that integrating behavioral health into primary care was essential. The General Assembly had access to behavioral health care, particularly for pediatrics, as one of their biggest concerns. Our surveys on retention showed that ability to provide mental health services was one of the biggest drivers, or inability to provide mental health services, of people leaving the primary care profession because it was causing such high rates of burnout. And health plans were desperate to have providers that that their patients could be referred to. So we tackled that. We developed an integrated behavioral health pediatric model that two of our health plans came together. And we now, for participating practices, they get both an upfront infrastructure payment and an increased PMPM. And for all of the practices that are participating now that serves Medicaid children, they are all at the highest tier, which is a tier 3 level of integration, receiving the highest PMPM, and it took a very short amount of time. That's the kind of thing I think rural health transformation could help do, because they needed that upfront infrastructure investment, but once they got there, they could make the payment model work. So it's some of those it's really listening across your providers and finding what is in that, intersection of the Venn diagram that everyone is most concerned about and trying to tackle it.
Also sounds like getting all of the stakeholders around the table to recognize those commonalities and shared goals.
We met for the first 2 years once a month at 7:30 in the morning. And we had amazing attendance. That's how important this was. We've reduced it to quarterly now. And we meet at 8:30 and not 7:30. But what we thought might be a 1 or 2 year initiative, we're in our 6th year and we are now in the base budget of the Virginia General Assembly. So it's just really important and everybody gets that.
Kevin, Beth, first, Kevin, thank you so much for posing that question. Beth, thank you so much for the insights, especially in thinking about just how quickly all of this unfolded in Virginia. I think it provides a really optimistic runway for what can happen in New York, as well as other states who are not necessarily engaging in this investment just yet, but how quickly you got to the how and then started to figure out how to build from there, I think is a really great lesson and sort of roadmap and thinking about where we can go next. And that leads me a bit towards my next question in thinking about if New York were to prioritize just 1 or 2 actions in the near term and thinking about investing in primary care, what do both of you, I pose it to both of you, and maybe Beth, I'll have you go first. What do you think would have the greatest impact and what needs to be in place to make those efforts successful overall? And I think you were just talking about one of those things, and it really is that sort of stakeholder and legislature buy-in and support. But on top of that, what else do you think needs to be in place there?
I'm happy to jump in first. I would say, for me, it's the data and the data analytics. You don't know what you don't know. You also, after we did I'll give you an example. After we got the General Assembly to do the first bump in Medicaid payment, one of the questions that I got that is fair and hard, and I have to figure out how to answer is, how do we know, given the different ownership arrangements in primary care, and given the different payment models, how do we know that increased payment is actually going to change clinician behavior and access? And the answer is right now, I don't. We are one of the things that we have put at the top of our list for this year is to look at primary care ownership and following the money. Because as more primary care is owned by, you want to call it private equity, you want to say health systems, you can pick different models. We don't know that if there is additional primary care payment, that actually makes it to the frontline teams and how they deliver care. And our General Assembly isn't willing to invest more if they don't know the answer to that. So, I come back all the time to, you've got to build the data infrastructure for this stuff. And that is hard and it takes work, but it's so vitally important.
It's always hard to follow, Beth, and I'm going to land around data and analytics. That's so near and dear to my heart. But I did also kind of survey so many of my colleagues, and I want to represent given that we have 2 things that we could offer, really having like strong multi-payer value-based purchasing programs, regimes in place. Primary care really does need strong, sustained funding, structural incentives to focus on long-term health outcomes. The information available to diagnose, treat, and refer individuals to the highest value care. Again, like doing this in New York State, as I mentioned earlier, could really affect upstream demand for high cost, high acuity services. And it's not new for New York. I mean, New York has a rich history of promoting primary care investments and innovation with a focus on behavioral health integration, as Beth mentioned, workforce availability and capabilities, and investing in health information technology and health information exchange infrastructure to support support these goals. And now it has an opportunity to build on that infrastructure and that history through its Medicaid VBP infrastructure, its long history with DSRIP, primary care first, CPC plus, patient-centered medical homes, where we now have an industry brought together, resulting in 2,000 practices to 9,000 providers participating. And it allows us an opportunity to build on that to introduce prospective flexible primary care payments, a standardized measure set, usable data for providers, and really making sure that we're bringing in those smaller and safety net practices to participate. But to come home to data and infrastructure, and just to reinforce the point that Beth was making, and I think some of the papers that we've released recently, you cannot reliably and structurally, in my view, change what you can't measure. We really do need health data in organization infrastructure in New York State to ensure our policymakers, our regulators, our industry leaders, and most importantly, our consumers, patients, and purchasers know where our healthcare dollars are going and the impact they're having. According to a 2025 survey, I think it was 79% of New Yorkers believe that we need greater investment in primary care spending, and we need a reliable all-payer baseline to understand where we're starting, and we need a steadfast and ambitious, in my view, all-payer target to get there. Beth mentioned having a high-functioning APCD in Virginia. Really having that infrastructure is essential and a prerequisite to really make sure that we're getting to where we want to go and are making progress, in my view.
Kevin, if I could just jump and just
Yeah.
follow up with that, because I think one of the things I want to make sure doesn't get lost in this is that just like in Virginia, we seized the moment that we had, right? I mean, I said we had national primary care leaders, we had a physician governor, we had a pandemic, and it was like, okay, here's, and we got started where we could get started. I would encourage New York to do the same thing, because whatever's going to happen, if you start with an investment bill, awesome, because that investment bill is going to make you figure out the data. It is. But, I would just, where the energy is, you just need to start people talking and making this a priority and moving in whatever direction you can get some energy behind, because it's really, really tricky work. It's really hard work. I don't think any state has figured out like this is the magic. But those that have worked at it, and I'll look, I have monthly calls with, Maryland, Delaware, Colorado, Massachusetts, we all huddle up and talk about this stuff. We're all doing it differently. But what's important is we're all engaged.
Well said.
Well said. And this is lending itself to a thought that I'm having, in that we'd be remiss not to mention the upcoming Medicaid cuts and the number of people that are going to be losing their health coverage. Beth, I know you alluded to HR 1. We've talked about the Rural Health Transformation Program and the ways in which that is, in a way, a complement, I'll use that word, to a lot of the cuts that are happening at the federal level. And in thinking about the number of New Yorkers that are going to lose coverage, the disproportionate impact this is going to have, not just on the health system as a whole, but specifically on the primary care system, and thinking about how we take a moment like this, similar to that of a pandemic, certainly a moment that no one wanted to happen, no one necessarily could have anticipated would happen, but was something that Virginia was able to use to move forward. Do you see an opportunity for New York to take this moment in which a lot of folks are losing coverage and turn this into a mechanism to further invest in and bolster the primary care system? And how do you think the best way to go about achieving that would be, especially thinking about the data perspective and how convoluted that's all going to become?
Want me to take this first? I would say that while HR 1 is unbelievably challenging, and I don't want to suggest I'm going to suggest a couple of things, but I want you to just keep the magnitude, perspective, because what I'm going to suggest are some things that might help, but they are not going to alleviate the challenges of HR 1. But what I would say is this is an administration at the federal level that is promoting a prevention agenda. If you truly want to promote a prevention agenda, you have to have strong primary care. I think most of us would agree that the wellness influencer community is not adequate to address the prevention needs of this country, and so I think there has to be some common ground there in working with this administration to ensure that we have primary care access. I would also say that this administration has come out and been fairly critical of the physician payment scale and the work of the RUC. Those of you that are familiar with that and how basically the fee schedule is set. So again, I think there might be a possibility there. So there are a few avenues in terms of federal partnership to think about what can we do to strengthen primary care? You mentioned Victoria Rural Health Transformation. We should all be thinking about how we can use those dollars to, strengthen primary care infrastructure sustainably. But I don't want to understand. HR1 is going to make, we're going to have at least our Virginia data. I haven't looked at your New York data. We're going to have a lot of people falling off the insured rolls here. And we do not have a primary care infrastructure that is prepared to support them. I'll give you our doom and gloom number. We are, I think, second to last in terms of federally qualified health centers per capita in the country. So, if that's where people who have no coverage go, we're in a lot of trouble here in Virginia.
We were actually just talking about the strain in particular on federally qualified health centers quite literally this morning, and that in and of itself is a major concern. So great call out there. And I also want to mention your reference to the Medicare physician fee schedule and the RUC, another great win in the primary care field. So I'm really glad that you mentioned that as well, and thinking about ways in which we can work with the administration, especially in thinking about their prevention agenda. Kevin, is there anything that you wanted to add before we pivot to, there's at least one or two questions in the chat so far.
I think it's another important consideration. And going back to your earlier question of why now, I think we really need to think about the long-term sustainability of our healthcare system and not further losing ground in what is the bedrock of our healthcare system and the gateway for many people to access care.
Yeah, absolutely. So one question in the chat so far from Patrick: would it be better to reframe and fight for primary care as a fundamental right available, in parentheses, at no cost to every New Yorker, funded by New York general taxes, contrasting that to continuing the marketplace supply demand framing of calling for increased investment in primary care as a commodified good? And this is reminding me again of a conversation that I was just having this morning about the New York Health Act and how that's been in the legislature for a number of years now, and how a sort of single payer system is, I think, a lot of folks' ideal when thinking about a system where everyone has access and is able to seek the care that they need. And that's something that New York has been striving for. But I'm curious, Beth and Kevin, your thoughts there, and thinking about sort of the reframing of the conversation as opposed to, like Patrick mentioned, the sort of marketplace or supply and demand context.
I see Kevin sent it up to me first because this is a really hard one and a really political one. So let me, and my job is based on building consensus and collaboration. So here's what I'm going to say about the challenge of that. We've tried in Virginia to think about some really innovative models. And the challenge that you have is, even if you could get consensus with your state government, right? Like if people came together, in order to do any of these things, you have to have multi-payer alignment. We've seen time and time again where payment models fail because you cannot ask a physician practice to, change absolutely the way they provide care for X% of their patients. And so I guess what I'm throwing back as a question to the group is, how would that practically work? Like, would your national employers no longer have to provide employer-sponsored primary care to their New York employees, but not to other employees? How would that work for veterans and federal employees? And there's just, we're so complex that it's challenging to me to think about how you would do a state one-off that is only primary care, and they would still need insurance for everything else they would need to access. But maybe I'm not understanding the question fully.
Yeah, I mean, I agree. And Beth, I come from it from a similar place, and it might be because we are so at least I am so kind of focused on how to make progress within the very complex and fragmented healthcare system in which we work, where payers have their own types of delivery systems and mechanisms and are reporting to different authorities in supporting care delivery. So I think that from a policy perspective, I very much agree. But I think that the other tricky part here is the political question. And as folks are really thinking about where we want to aspire to in our healthcare system, I would encourage everyone to kind of like reach out to their local representatives to really make sure that their views, their values, that what they're hoping for from their healthcare system is represented, especially as we think about this year.
Thank you both. And I think something that in listening to your response and sort of tackling both the political and the complex nature of that question, in that I don't think the two are necessarily mutually exclusive. They are two very important pieces of the puzzle, in that sometimes, even though we as sort of policy folks or advocates or whatever hat we may have on, want to lend ourselves to the community engagement aspect of it, thinking about health as a human right, et cetera, we also have to think about the mechanisms in which we achieve those things. And because the system is so complex, we can't divorce them from one another at this point in time. So it's
Yeah.
ensuring we sort of push them forward in the same capacity.
And can I add to that, Victoria? And then
Yeah.
Beth, I saw you poised, and I really want to know what you think too. I also want to note that this could be a journey, and like one of the things that Beth that you mentioned before is not giving up an opportunity or a moment to start to make progress and change, because that's how you build new systems. And like I've been doing a lot of work in California, among many other states, where they establish an overall cost growth benchmark. They establish their own primary care target, and they're developing systems and capacity and resources in order to support these different aspects of the healthcare system, which we know are in our long-term interest to support and invest in. And again, like by making those steps, you might actually get closer to realizing some of those long-term goals for what you want out of the healthcare system. But we have to start with the moments and the opportunities we have in front of us. But Beth, I don't know if that resonates with you, and I know you were poised.
I just I come back to, I mean, I think I'm conflicted in answering this question because I believe that states are where the energy is right now. I don't think you're going to get the kind of change that really any of us might be hoping for to support primary care at the federal level in this moment. I would love to be wrong. And, if I'm wrong, I would be delighted to get the phone call that, things have happened. But I think the energy is with states. The challenge with that is that, as I mentioned, it's really hard to get multi-payer alignment across states for significant change when most of your national, your big employers are multi-state initiatives. And, they're in California and New York and Virginia, and, they're going to start screaming at me if we're all making them do very different things for their employees in those states. So, I've been in this profession long enough that here's what I would sum by saying, I wish we had the courage as a country to take a bold step in change how we fund primary care. In the absence of that, I'm moving forward with as many little incremental changes as I possibly can.
That is beautifully said, Beth, sort of, especially in a statement to wrap us up. There's one more question in the chat. If you had like a very brief answer in how Virginia is attracting new primary care providers, thinking about the lack of providers in New York State and knowing.
Oh, we're not doing any better than you are. I mean,
Okay.
we're not. I wish I had words of wisdom that we were somehow magically doing that, but we're not.
So that challenge continues clearly, and it's one that not just New York is facing, but obviously many states across the country, including those that are doing the work in attempting to increase investment in primary care. So I just want to wrap it up really quickly. I want to thank both Beth and Kevin, and of course, Mary, for starting us off in the really insightful and productive conversation. It was so appreciated. I hope everyone enjoyed. Just a reminder, a recap will be sent out with the recording, and please do stay connected with New York Health as well as our speakers. And thank you so much for joining us.
Thanks for having us.
Thank you.